floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
Welcome everyone to the Crisis Jam. My name is Heather Honecker. I'm your host today. We have so many great speakers and presentations coming up for you, including our feature with Dr. Miriam Delphin-Rittmon and Susan Lange talking about the behavioral health crisis workforce. Very excited to dive into this important discussion with them today. Want to remind everyone that we have a website, crisisjam.com. You can go there to find the merch shop. If you're interested in having a 988 hoodie or a t-shirt, you can go there. And in addition to merch, you can find ways to access Crisis Jam. So information for Zoom, if you are live streaming, you can connect with that there. We would love for our live streamers to join us here on Zoom today if you're able to. And if not, go ahead and make sure to like and subscribe to that channel. You can find recordings of every Crisis Jam episode here. So if there's something that you missed or want to go back to, we have many episodes there. Again, go ahead to the YouTube channel, like, subscribe, and find what you've missed there. So in our last jam, we asked the question, we want to bring it up in a poll today. What percentage of crisis jammers would be comfortable with their healthcare providers using AI tools? I believe we'll be throwing a poll up there for you to answer. So again, how many of you would feel comfortable if you had a healthcare provider who is using an AI tool in care? Go ahead and take a moment to answer that. And just to call back to our pre-show, wanting to know what zero suicide looks like in your community or in your state, you can enter that in the chat. We'd love to hear from you throughout our time together. Now time for breaking news segment. We're going to bring in Dr. Brian Amadami with Henry Ford Health and the Zero Suicide Initiative. So go ahead and pull him up here with me. And I'd also like to invite Dr. Richard McKeon up to honor Brian.
Thank you, Heather. We just wanted to interrupt this introduction of Brian to make sure that everyone knows that Brian was recently honored by Time as one of 100 top healthcare leaders, not just in the United States, but globally. I've been pleased and honored to work with Brian over a number of years. And in fact, when he got a zero suicide grant a number of years back, I immediately appointed myself project officer so I could learn as much as I could about the work that he was doing. So congratulations, Brian. It's well deserved. You are clearly a global and international leader. So now to Brian.
Well, thank you very much, Richard. I sincerely appreciate that, to you and to everyone here. It's awesome. And I think first and foremost, I just want to say thank you, because I'm so happy that they're willing to focus on suicide prevention. And, you know, that's not a typical topic that they put in these kinds of lists. So I feel blessed that they did that, and that we have a platform to showcase suicide prevention at a big stage like Time, that can get a lot of attention and help us continue to move forward to make a difference. And, you know, anytime something like that happens, it's because you have incredible team and people who care and want to do something. So I think it's all of those things combined. And I really, you know, more than anything, our goal is to try to make a difference in partnership with all of you. So thank you so much. I really appreciate it, but, you know, also recognize that there's tons of work to be done, and that takes a village, and that we all have to do that together. So thanks. I do want to say, you know, take a look at the screen. With that all in mind, I want to showcase the fact that we are hosting the 6th Zero Suicide Summit. It'll be in Bali, Indonesia on October 12th through 14th. There's a welcome dinner on the 12th, the 13th and 14th all day. Please do, you can go to zerosuicide.org. We would love to have you participate. I'm telling you, we had a chance to go there last fall. It's absolutely spectacular. The people are amazing. I think this is going to be an outstanding program. There will be a registration link available within the next month. And if you have any questions, you can just send a message through our contact portal there, and we will make sure that you're on our list to get the registration information when it becomes available. But please, visit our website and mark those dates. We would absolutely love to have you join us in Bali later this October. So, and reach out if you have any questions. Thank you so much for having me on, to everybody here.
Fantastic. Thank you. And congratulations again, Brian. What an honor and just what important work you are doing. Right. Now we are going to move into our hot seat segment, and we're going to invite Dr. Phil Mooreback and Dr. Dove to join me. And we invite you all to play too. So the question will pop up on the screen, and you have an opportunity to win some Crisis Jam swag. So welcome, Phil. Welcome, Dr. Dove.
Hi.
Question for today.
Hello. Nice to see you all.
When London's 999 emergency number rang for the very first time in July of 1937, what happened? A, an attempted break-in Hampstead. B, someone called for a suspected heart attack in Soho. C, a warehouse fire along the Thames. And D, a prank call from a telephone box in central London. So what do we think the answer is here? For those who are joining us, go ahead and answer on the box that popped up. And then Dr. Moore, Dr. Dove, where do you think we land?
What do you reckon, James?
I mean, I was going to make some comment about something not working, so I would have to go with prank call, would be my first guess.
I wonder if that isn't the right one, to be honest. It sounds pretty typical. I'd go with D.
Okay, why do we think that? Is that a thing that happens commonly? Kind of talk us through your process, how you landed on D.
That's interesting, isn't it, Phil? I don't know if we're having the same. It's the kind of British humour kind of aspect, perhaps, that makes me think. And also, obviously, you know that we have socialised healthcare and NHS, and it is fabulous. But at the same time, a lot of things don't necessarily work all that well at the start. So my first guess was going to be, actually, it just didn't work. So the first call never got answered or something like that.
I think a prank call is typical British humour. I suspect somebody was just trying out this new thing to see what happened. It might be wrong, but that would be my guess as well, James.
All right. It looks like many of our participants today thought the same thing, but let's go ahead and see what the answer is. The answer is A.
Oh, wow.
Break-in Hampstead.
Oh, well, you learn every day, don't you?
Yeah.
You learn something.
Architect, excuse me, John Stanley Beard was awakened by a burglar beneath his bedroom window, and his wife dialed 999. The police made an arrest within 5 minutes.
Wow.
So not a prank for the first call.
Oh, well, James, we got it wrong.
I mean, it's interesting, isn't it? These things take so long to embed. My first thought is, how did this person remember they had to call this number? Because we all know how long it takes to embed this kind of work culturally. So
I think it does take a long time. I'm surprised it happened as quickly as that. But I agree, 5-minute response time. What's the mental health crisis standard in 2026?
Oh, God. Yeah, I hate to think. Well, this was pre-NHS, actually, isn't it? 1937.
Pre-NHS, yes.
Or this.
takes us into our next segment. Thank you, Cookie Monster, the over-under game. So over-under, people in mental health crisis are waiting up to blank blank in A&E in England.
Oh, goodness me.
So this was published in The Guardian in May of 2025, where the article cited people in mental health crisis waiting up to blank blank in A&E in England. Phil, how about you give us your answer, and then James will have you say if it's
It depends. It depends if this is in general or the maximum anybody has. I would probably go with 10 hours. Waiting up till that time, it would be unusual. I think now they're seen a lot quicker than that generally, but I would say up to 10 hours. What do you think, James?
I'm with Leanne in the chat. I go over, but the qualifying factor I'd like to know is waiting for a bed or just waiting to be seen.
That's right.
Because we have KPIs, key performance indicators, we should see people within an hour in ED, in emergency departments, and we generally are pretty good on the hour response. The long waits happen when people are waiting for a bed, which I know from being involved in these conversations is pretty typical nationally as well. But I would guess it means beds, and therefore I would guess I would go over.
for boarding? David provided some extra context
For
in the
boarding,
chat.
what does that mean? Is that section, is that detaining? Boarding.
That's waiting. That's trolleys in
waiting in-
A&E, basically.
Okay.
Let's see where we landed here.
That's UCH on the picture. That's one of
3
my hospitals I
days.
work in. Oh, over.
Way over
Okay.
there.
But that would be people waiting for a mental health inpatient bed.
Yep.
There is-
Our next steps, waiting
Three-
for a
three
bed, for
days?
care.
Gosh, that's very unusual. Don't you say, James?
Well, I would like to agree, unfortunately. So I'm currently sat at North Mid Hospital in Tottenham, but it does unfortunately happen.
Okay.
So yeah, I'm afraid I'm not as surprised as you, Phil.
Yeah,
Well,
and we
maybe-
see
maybe
this
I-
happening in the United States and in other countries around the world. So certainly not
So this
an
is, if it
isolated,
is
yeah.
waiting for a bed, I think you're right, James. It does make a difference. I think most people would be seen and some kind of intervention done way before that.
Oh yes. Lots of work done over those 3 days. I would like to.
Indeed.
Thank
Be
you both
sure.
so much for joining us for
Thank
that
you.
segment. We'll
Thank you.
get now into our lead story. We feel so fortunate to have Susan Lange and Dr. Miriam Delphin-Rittmon joining us today to talk through building the behavioral health crisis workforce. Right, and Dr. Delphin-Rittmon, I'm going to go ahead and turn it over to you.
All right, thank you. We are thrilled to be on and to share a little bit about addressing the crisis workforce training needs and retention strategies. And so what Susan and I are going to do in our time, we're going to focus on challenges for those staffing their open positions, as well as some of the opportunities for, supporting existing crisis workforce. We'll also hone in on training needs. We know training is so important, so we'll spend a little bit of time talking about some training needs and really speak as well to some of the supply and demand data with respect to the crisis workforce. And then I'll pass it forward to Susan, and Susan will end with talking about some short, intermediate, and some long-term strategies for bolstering the crisis workforce. So next slide, please. So we wanted to start with this slide. This is a poll question that we did, I believe it was last month, where we asked jammers, what do you see as the most significant skills gap in hiring the crisis staff? And there were a range of responses, and you see how it sort of lays out here from this diagram. About 18% or so said that, prior crisis intervention and de-escalation strategies. About 35% talked about, folks needing additional training and skill with respect to working with high acuity individuals in unpredictable environments, cultural responsiveness and community engagement. That was at 10%. 10% also in terms of lacking calm communication and sort of skill building there. You'll see the other areas that came forward in the poll. And again, we so appreciate everyone's sort of participation in that. Next slide, please. Our remaining slides will sort of talk a little bit about, again, some of the gaps, but training needs, opportunities. This slide here, we want to include this. This is from an administrator, an individual that is actually running a crisis continuum program. And it really gets at sort of the sort of opportunities around just broad and early training. We know that training makes a difference. And it is such a valuable and viable resource and need for crisis care staff. And that ultimately an individual doesn't have to be in the behavioral health field, that it works to bring in others and to have training often and early, and that can help in terms of addressing workforce capacity within the crisis arena. Next slide, please. I wanted to talk also a little bit about, we wanted to share some content related to just the supply and demand. As we look over time, we're increasingly seeing that, for example, this first NRI study, talks about there are about 34 out of 43 states who provide accessible data, reported moderate or greater shortage, specifically in terms of mobile crisis workforce. So shortage in terms of mobile, but not so much in terms of the crisis call center staff. And it may be, for mobile, it means sort of being out, crisis call center. In some instances, people are able to do that work from home or from other areas, not in the community. So, often important to sort of unpack what's driving what, but I think that does speak to some demand issue. The next area as well, 50 states reported into this study. Again, another NRI report from one of the Crisis Jam sort of meetings. But anyway, 50 states reported mobile crisis data. And the findings showed that approximately 2,448 mobile crisis teams. But when we look at the number of individuals seeking mobile services from 2022 to 2024, what an increase from, over 288,000 to over 1 million in that short period of time. So that as well speaks to the sort of demand for mobile crisis workforce and individuals being able to provide support at that level. And then the last slide as well, point as well, speaks additionally to some supply and demand issues or areas. Next slide. I'll share one more quote. And this quote again gets at the same thing, the idea for that, training is so critical. That the crisis workforce, it's an important area in terms of having ongoing training opportunities. I'll pass it now to Susan, who will share a little bit more about credentialing within the crisis arena and some of what, real value that can come from some of the credentialing opportunities, but certainly some of the challenges there as well. Susan?
Thanks, Dr. Delphin-Rittmon. Next slide, please. So I want to start this piece in talking about some additional challenges. So Miriam lifted up in terms of the skill gaps. So when folks are sourcing for their crisis workforce, what the skill gaps are, there's some additional challenges that we want to just surface today. But then we are going to rest in the space around recommendations, because I think that there are ways to mitigate some of those challenges. So the first one is the need for established competencies and more uniform training practices for mobile crisis workers. I think, we've heard from providers that really, time is of the essence. So the training can often be quick. One of the other things is training oftentimes is greater than 6 weeks long. And for smaller programs, that's really hard to fit that in when the demand is high. And so they need to have the folks who are ready to go. And so training to spend that much time up front can be challenging. Having established competencies, so there's consistency across sites and programs, is really, really important. And thinking about preparing the crisis workforce. And so that bubbles up in what we saw in some of the skill gaps of not having enough folks who are able to deal with high acuity caseloads. SAMHSA has a draft toolkit and for the crisis workforce, and some states have developed their own materials for bachelor's degree and master's degree level staff. But we need strategies that we can rapidly scale up folks, and particularly focused around the competencies and thinking about representation in the workforce and making sure that folks both at the very early career level and developing out career pathways mapping so that folks have upward mobility opportunities within the crisis workforce. So despite the challenges, I think that there's some ways that we can get creative around meeting the demand. I mean, Miriam lifted up some of the statistics going from less than 300,000 calls to over 1 million. So demand is high. So having a robust pipeline is really important. And what we know in terms of retention, doing a replacement strategy to replace for every one crisis worker that exits, having one person coming in is not enough to meet the demand. So we really need to have a more robust pipeline of folks getting prepared to go into the crisis workforce. So the first recommendation is to invest in workforce development. The state of Washington has a behavioral health registered apprenticeship program. And they are building out new pathways for that. So behavioral health technicians, peer specialists are among the roles. And they use the apprenticeship model to really give folks hands-on experience and use stackable credentials so folks can build their skills to be able to enter the workforce. So that's one model we wanted to lift up. The second is the idea of building a credential that focuses on the competencies for crisis work. And we talked a little bit about that as a challenge of really needing to have established competencies to focus on this work, rather than attaching those competencies to existing credentials. There is work that is underway that's being funded by the National Alliance for Mental Illness. And they are proposing a community behavioral health crisis responder credential for folks as an entry-level position. Those are designed for folks without college degrees and intentionally for folks for underrepresented groups. So thinking about, oftentimes college can be an obstacle for some folks based on cost and entry points. So having credentials that are stackable, that give opportunities for folks to enter the workforce and then map out those career pathways that allow for upward mobility to make sure that there's better representation as folks move up within the pipeline. And then the third recommendation here is to establish regional centers of excellence at community colleges or other organizations that really would get at supporting the standards, the training, and the technical assistance for the crisis response workforce. So really baking in the workforce development strategies as a way to build that pipeline. Next slide, please. So this, I want to turn to, so that was about credentialing, but there's some other strategies that we want to hone in on here that are short-term and medium-term to grow talent, to sustain your existing teams, and really to expand the impact of the crisis workforce. So we'll walk through some of these ideas now. So the first is to standardize scaffolding onboarding for folks within the first 90 days or 100 hours to build in some capacity-based hiring and structured training and really support the supervision and the mentorship. So I think we see a lot within workforce development. Giving support to middle managers is a terrific retention strategy within workforce. Certainly within crisis, but in all levels of behavioral health. So making sure that the supervisors are well equipped to support their frontline workers is a way that is going to improve retention. implementing a comprehensive retention menu of resources. So making sure that there are debrief protocols when folks are either coming back in from a mobile crisis call or being on a really tough call within a 988 center, having space for folks to recharge and reset, building in clinician office hours for staff so people have an outlet to really talk through some of the more challenging things that they're dealing with when they're out on a mobile crisis call or on a hard call in a 988 center, and really making sure that as leaders, we're baking in resources and supports for the existing staff. The next is to adopt flexible staffing models. So again, for high intensity roles, rotating tasks, and changing the cadence for staff to avoid burnout and turnover. So I think, Miriam, you lifted up a little earlier, one of the challenges with the mobile crisis workforce in this age, post-COVID, where folks often are opting for remote work, that is one of the challenges in getting mobile crisis staffing levels up. So when offering models that allow for those high intensity roles to have some task rotation and to change the cadence as a way to reduce the burnout and turnover is an important element here. Strengthening career outreach to crisis work, so competency-based messaging, stigma reduction, highlighting empathy and social justice. And I would put an exclamation point on engaging schools and career fairs. I think we see oftentimes, thinking about at the middle school and high school level, particularly within career and technical education, we see healthcare as a track, but very, very infrequently do we see behavioral health, and certainly don't see crisis work as a way to have young people explore that as a career pathway for themselves. So I think that's a good way to make people aware that that is a path and an opportunity that they could explore. And then lastly, integrating supervised professional experience for folks. So within crisis centers, to expand the pipeline, aligning that supervised professional experience requirements with the crisis system roles as a way to better support the existing staff. Next slide. There we go. All right, and then we'll go back to some longer term strategies here for supporting the workforce. So we already mentioned the doing apprenticeship as a model. It really is a terrific opportunity to have folks engage in a really hands-on way, learn those skills, and get a real feel for what the work looks like. So it's an opportunity to expand a new way to engage folks within the pipeline, and adding the credential, as we also talked about, the community behavioral health crisis responder. But here's some other opportunities in terms of thinking about things that take a little bit longer, but are going to broaden that pipeline strategy. So position the organization as a teaching organization. So that helps with folks understanding that what their path could be, and could better position them to understand that they could have a 3 to 5 year growth trajectory within an organization rather than a revolving door. And so use it as an opportunity for folks to feel like they're really engaged in their own development by positioning the organization as a teaching one. Create equitable funded retention initiatives. So offer milestone bonuses for the 2, 5, or 10 year markers. And give incentives for folks in the community-based or rural services, where we see oftentimes greater staffing challenges. Build formal education pathways. So the associate's degree in crisis care, integrate modules into existing certifications. So, going beyond just what has been traditional bachelor's degree or master's degree level pathways within behavioral health, having stackable credentials that allow folks other entry points and really speak to folks who traditionally have been underrepresented in the behavioral health workforce are important for developing that pipeline. Establishing a recognized career ladder, so crisis services certification and really giving experience-based pay and promotions, and having folks understand what the career ladder might look like. If it's a guessing game to folks, they are less likely to stay. So that's having a mapped out career pathway is a really good way to hold on to your existing staff. And then lastly, ensure the market competitive roles and salaries. So align the compensation with the cost of living and comparable fields is another way to have this crisis work be really appealing. And the last slide. So if any questions, more than happy to engage in conversation. There's my contact information. I'll turn it back to you, Miriam. Oh.
Yes, so I know we have Stephanie who is going to come on and give some brief comments, and then also, and then we'll have some roundtable questions as well. And so we'll turn the floor over uh, to Stephanie Felder, who is a director of a comprehensive crisis service system of care. And Stephanie, so glad that you're on. And would love to hear some of your comments, and then we have some questions for you as well.
Well, thank you for having me. I'm glad to be here today. As I was listening, all the things that both you and Susan said have resonated and have uplifted some challenges as well. Um, I do agree with about the certificate program for crisis response and creating different pathways, but I really highly want to uplift that underserved population, how hard it is and challenging for them to go to school, finances as well. And then a lot of times the populations we serve aren't represented by individuals that look like them. So I do want to keep that in mind. One of the things the state of California has done is that when they created every county had to have mobile crisis teams, is that everyone at all levels had to be certified in crisis response. So they actually, it didn't matter if you were a master's degree or you're someone that we're just hiring interested in crisis, a peer, health worker, everyone across all the organization providing mobile response had to be certified in those classes. So I thought that that was a good way of helping underserved populations at least get their foot into the door of this type of workforce.
Yeah, yeah, absolutely. And wonderful to hear that, that there's a certification program and that California is looking at sort of the diversity and working to have a team that matches the individuals that are calling in. Such a valuable strategy in terms of addressing diversity and equity for individual callers. Are there any other gaps, I would say, that you are seeing or experiencing? We started with that poll question that laid out the range of areas that individuals who are on one of the previous crisis call or crisis jams mentioned. Yeah, so this slide here. Are there others that you're seeing within your organization as you work to sort of build out your team and ensure that you have individuals in the positions where you're needing folks? Other challenges or even opportunities that you see?
So some of the challenges that we see, crisis work is unique and demanding, as we know. And so what we're seeing is a lot of the candidates that come in for hiring or trying to hire for positions are not fully prepared for the intensity of the role or for where we have to conduct assessments, such like in the field or in people's homes, and we go on the streets at times, and sometimes the places we visit, aren't what people are used to going into and doing assessments. It's not in like a brick and mortar. Get very creative at times.
Mhm.
So those are the challenges as far as hiring staff and also supervisors. We really do have even a higher challenge with hiring supervisors as well, which has a lot to do with the hours because
Yeah,
we're for our 7-day-a-week service.
yeah.
Um,
Yes. Yeah, such an important point you mentioned, because we often will talk about the crisis workers or the mobile crisis workers or the call center staff. But you mentioned an important piece, the supervisors, the supervision of those individuals. That is an important workforce sort of segment and group to consider and do work around as well. So thank you for mentioning that. Such an important area.
uh,
Susan, I think you had a couple questions. Oh,
I
go
did.
ahead.
Yeah, Stephanie, I'm wondering about your reaction to the short-term and medium-term strategies in terms of growing your talent. So one of the questions I see in the chat is, how do you strike that balance between workforce development and meeting demand, especially when you have staffing shortages? So anything you would lift up or offer up in terms of strategies that you might have used to both bolster your current staff and deal with some staffing shortages?
so that definitely is a challenge for sure. So what I would like to kind of emphasize on that for our team, we're both the dispatcher and the responder. So it definitely gets shortage of staffing. We have tried to emphasize willing to, and depending on what your skill is, being flexible, staff, being empathetic. Also, we have offered other opportunities to kind of curb some of the burnt out. Unique for our crisis agency, we're able to offer like, okay, if we see people are burnt out, they may have the opportunity to do more of the community outreach, do debriefing services. We're a true crisis agency, so we do a lot of debriefing, supporting in the community, as well as we have a small team that can provide therapy to help support through the crisis as well, which we find helps to sustain staff. We also emphasize a lot of self-care, trying to cultivate and build a culture of self-care to say that it's okay. You had a hard crisis. Maybe you need to take a mental health day, that you need to take care of yourself. So we support that, even if staff come back, because we also respond to homicides and shootings that it's really challenging and hard. We let staff go home, take care of yourself. Right. We bring food to the office as well. Food is a big thing that we have. We cultivate cultural diversity and celebrate staff. We also make sure we offer what we call shout outs or kudos to staff during our staff meetings and emails to help support sustainability and to let your staff, it's very important that you appreciate their work and that you recognize them as well. Additionally, we, as far as trying to recruit staff intentionally, what our county has done is hired what they call public safety trainees. And so there's second year master's level degree that are, just starting, getting ready in their career, not sure what they want. We have actually hired them maybe at a slight lesser pay than we actually pay our clinicians to come in for 9 months to give them the exposure to crisis work so that they are aware and to determine whether or not that's the career path. We have been very successful. We've actually been able to hire people when we couldn't hire positions through that program. And help people who were thinking of, just doing outpatient to really, oh, we do enjoy crisis work. So that has helped. We also have a 6-week cohort. Every 6 we partnered up with one of the community-based organizations that hires high school students. It's called FACES. And we allow them to, it's designed to introduce them to the field and to build a foundational knowledge of crisis work. So they come in, the high school students, we expose them to like mental health services, psychological first aid, diagnosis. They sit in on our crossovers to hear about cases. So that way we give exposure to crisis work and being intentional on trying to start recruiting from that level as well.
Stephanie, I love that idea. That early career exposure, I think, can really make a world of difference for folks. I think oftentimes folks who end up in the crisis workforce either have lived experience themselves or might have family members with lived experience. But folks who might not have that, having some exposure to understand that this is a real viable career pathway for themselves is a terrific way to open up their eyes and the avenues to build the workforce. So thank you so much for lifting up that idea. Anything else in terms of long-term strategies that you would add?
In terms of long-term strategies, and I would look at the pay scale. In the challenges that we face, because it is a union, we are city and county, is that it is not comparable. There's no premium pay for crisis work. Crisis work is intense, right? If you work at a hospital, there are different levels of intensity, and people are paid depending on the intensity of their work and the health. But in crisis, if you work in outpatient or you work in crisis, you're getting the same hourly rate. So that makes it challenging, because why would I work for a 24-hour clinic when I can come in the office, work 9 to 5 or 11 to 7, stay in my office, not have to go out in the field, wake up in the middle of the night for the same pay. So we definitely need to get some type of premium pay for crisis workers. I always think of it as like the heart surgeon or the brain surgeon, maybe getting paid a higher rate than other types of surgeons. Just like crisis workers, we are take the most acute clients. In our agency, sometimes we have to hold on to them. We can't even pass them off to outpatient because they're too acute. So we are even stabilizing patients. So why shouldn't the staff there be rewarded with a premium pay, which would be a better incentive of getting them in the workforce?
Yeah. Stephanie, you're getting a lot of love in the chat for these recommendations. They're practical, they're doable, and they're pieces that can really make a difference in terms of helping the workforce to feel supported, heard, giving them opportunities. I love that you mentioned self-care, that there's opportunities for folks to take an extra day, mental health day if they need it, or to go home if they've had a tough call, or to, that you guys feed each other, you break bread together. And that can form such an important sense of community and support across the teams. So really appreciate hearing the different strategies that you've laid out and that you're implementing. Are there recommendations that you would offer for crisis call centers for teams or mobile teams, that are steeped in this work as you are and your teams, in terms of just sort of keeping the work moving forward? You all are doing such important work in terms of meeting people's needs right where they are and showing up when people need support. What recommendations would you give for your colleagues also steeped in the very work that you and your team are as well?
I would say make sure that you appreciate everyone, your staff, your colleagues, your coworkers. I would recommend all things that even with a certificate that staff appreciate training. They also appreciate when there is standardized calls. even though we need to remember that each client is different, an exception, and also always recognize the cultural diversity, not only within your staff, but also within the clients that we serve, and to meet people where they are and to adapt to those cultural diversities as well. For us, I just want to uplift that we are probably fortunate using crisis work. From my understanding, people turn over within 2 years. Most of our staff have been there at least 5 years or more. Some 20, 25 years doing this work, which is intense. So that speaks to the passion. It's not for everyone. You have to have a passion for this work and for people as well. So those are one of the things. And also self-care. I'm a real proponent of pushing self-care and whatever that looks like, and helping your staff and recognizing that. And one of the things I didn't uplift, I wanted to say, is for our staff, we hired a consultant to support them with the impacts of the work. So that person was coming in monthly, meeting with the staff. They had a place to kind of download, talk about any contract insurance, talk about any of the management issues, all of those things to help unload, which I do help. I think that will help with sustainability. I highly recommend it. I know everyone may not be in budget, especially now. Budgets are very slim, but I do recommend that, and to build in debriefings after building the infrastructure to challenging crisis. It has to be built in. It has to be built in somehow. It's hard, especially short of staff, but you have to follow up with your staff to help take care of them so that they can continue to do the work.
Thank you so much, Susan, Miriam, and Stephanie. It's so great to hear just so many actionable steps that folks can take and engage. I especially loved hearing the support for middle managers. I don't know how many of us can relate to being a good responder or clinician, and suddenly you're promoted to manager, trying to figure out what to do next. So thank you all so, so much for joining us and sharing. Now we are going to shift gears and head to the briefing room and invite Dr. Richard McKeon up to share some updates with us.
Thank you very much, Heather. Glad to be here as always on the Crisis Jam. A couple of notes. I've been doing a countdown for everyone, but there are now 2 days remaining for the funding opportunity at SAMHSA to remain open for the 988 network administrator. So if you haven't started, you're probably in trouble because it would takes time, effort, and work, obviously, to put in the application, particularly for one that is this significant and so crucial, so critical. And this annually, this is for over 200 million, 231, I believe, over annually for a 5-year period. You do the arithmetic, and that's over a $1 billion investment in 988 over the next 5 years. And that money is not the only 988 related money coming from SAMHSA. Again, be on the lookout for upcoming funding opportunities for state and territories for 988, the tribal 988 grants, as well as the Crisis Center follow-up grants will all be coming down the pike relatively soon. Also wanted to let you know, and you'll be hearing more about this, and you can talk about maybe how to feature some of this on the Jam. But we were very pleased that we received partial approval, or I should say OMB approval, for part of our 988 and crisis evaluation. I've often referred to this evaluation as being the most ambitious effort ever to evaluate crisis services in America. So it's a really important evaluation. It's very complex. So they've not ruled on all of it yet, but they have ruled on part of it and given the go-ahead. So we're going to be start working on that while continuing to communicate with OMB about the parts that they are still reviewing. So more to come on that. So thank you very much.
Thank you so much, Dr. McCann. And now we will welcome up Wendy Morris with an update from Nashville.
Thank you, Heather. That presentation, feature presentation today was just amazing. All the information on workforce was so great. I do a lot here at Nashville in the workforce space, and I just want to build on a couple of things. There were a couple interesting gaps that you all pointed out. That first, where folks, it's hard to find people who are trained in co-occurring mental health and substance use, but I want to point out being trained to work with people who have intellectual developmental disabilities and brain injury is also very important. We know 1 in 3 people, as one meta-analysis showed, who have intellectual developmental disabilities also have mental illness. So there's almost a certain probability that 988 callers are going to be working with that population. But a lot of the same things, apply. But I love that you also said that there was a gap in people's, ability to find folks who can be calm and can be patient when they're taking those calls. And communication is another one of those kind of universal things that we need to pay attention to when we're doing this work. But there's also the issue of augmentative and alternative communication, and that we all need to learn a little bit more about that. We know folks who rely on speech generating devices often get cut off from 988 calls because call takers think those are robocalls. So maybe we need technology that's going to better help us suss that out at the time we're taking the calls. But it can be very difficult for people who don't rely on the spoken word to access the services that they need. That goes obviously for people who are deaf and hard of hearing. But, all of us struggle with the verbal communication when we're under a lot of duress, if we've gotten some traumatic news or we're in a very overwhelming circumstance, we can really struggle with words to say. So we don't have to have a disability, right, to struggle with that. It's something that all humans deal with. And I had the honor of facilitating a panel earlier this week that was focusing on, looking at what we need to do, how we can better build services for people who have intellectual and developmental systems across the crisis system. We had 3 states featured. Every one of them said communication was an area where they recognized that they needed to do more work. The other thing I really loved was how you all talked about engaging people with lived and living experience. And I think it's so important to include people with lived experience in your training, so that employees can hear from people who've called 988 what that experience was like, especially in your state, because every state is a little bit different. So that's certainly important. We want to be sure if we bring people with lived experience to help with our training that we pay them the same as everybody else. I think there was some good comments about pay equity in the presentation as well, how important that can be. So I just want to bring some of those points up. The other thing I really loved was the focus that you all had on, that health and wellness of employees and how important that is for retention. You mentioned flexible staffing models and spaces to recharge and reset. This idea that maybe we can have some on-site self-care, rotating tasks, the ability to get support as we need it when we deal with difficult situations. I think that's true in a lot of healthcare. I'm a nurse by training. I've worked in the emergency room. So you've got to have that time and space to gather yourself right before you take that next call or you see that next customer. So anyways, just a really great crisis jam today, and grateful to be able to say a few words. So thank you.
Thank you so much, Wendy. Thanks for joining us and for those reflections. All right, I want to bring our friend Miriam back up as we reflect and think that it's almost been 4 years since the launch of 988, and we've got a throwback here of a previous episode of Crisis Jam. And so I want to get your thoughts. What are you thinking as we get ready to enter year 4 here?
Yeah. For one, the time has gone fast, but I just have a lot of gratitude. I mean, it's been so wonderful to see just the ongoing and continued collaboration. I understand that, monthly the rates remain high or even yearly, like since the beginning, over 19 million, individuals helped through the crisis line. And that's profound in terms of the just really vital work that's being done at the call centers, collaborating with the states and even the crisis jam, the work that happens across this jam. Early on, I would often say that this work takes a village, and it's been wonderful to see that the village is still very much at work. I travel a bit for my job now, and almost every state I'm in, I love still seeing the billboards and you go into parking lots and you see signs and all the different ways that people are working together to help get the word out to let people know, look, if you're struggling, you are not alone. There is a three-digit number and folks all over the country that can help you. And so it's been really nice to see the work that's been done there in terms of the messaging and just continuing to get work out. And then I understand, many states are now working and looking at the rest of the continuum. Still focused on, of course, making the crisis call centers themselves strong, keeping answer rates high. The SAMHSA team has been amazing there in terms of continuing to provide support, vibrant as well. And it's nice to see the work that's happening in terms of the rest of the continuum as well. That is standing up and expanding the mobile teams. Also looking at the stabilization centers to ensure that, when people connect with mobile or when they need to connect, in a more significant way, that it's nice to see stabilization centers beginning to pop up as well. So it's just been nice to see just the range of work that's continued to happen and to know that, people are getting support, they're getting the help that they need. And ultimately that really has been the ongoing goal.
Absolutely. There's still such a force and momentum behind this work that's needed. And it's really great
Yeah.
that we're still pushing it forward. I agree with you. I
Mhm.
love seeing all of the 988 signs that pop up if they're on a billboard. But my favorite is to see a sticker stuck in a random place. That someone got that somewhere and said, I want people to see this. And so I'm going to put it wherever I find them, on the back of a bathroom stall or at a restaurant or just all
Yes.
over. And so there's even a movement just in people around the country who want to spread the word, and it's great to have that support too.
Yeah.
I'm
Yeah.
curious, so if you think back to 4 years ago, what message would you tell yourself going into this work, knowing all that you know now and seeing all that's been built out in that time?
Yeah. Well, that's a good question. It's a tough one. I mean, I maybe a reminder about the marathon that, certainly the sprints are important. It was a sprint. It was a sprint with so many vital partners leaned in to be able to launch in a pretty short period of time, and then to be able to look at the various metrics and keep those high in terms of the texts, in terms of the chats. But I think another important piece is, remember the marathon that 911, right, was built over, I don't know, decades or just quite an extended period of time, and we're 4 years in on 988, and incredible work has been done and millions of people have been supported and helped. And so I think thinking long term and remembering that this is it's a major system change, right? Once in a lifetime system change, we often note, and that change will continue to evolve and continue to evolve and happen again through the amazing collaborations. Like this is can only happen and can only have gotten us to really this moment with collaboration across the board at the local level, at the state level, national partners all over the place, the JM, creating this community to be able to have conversation and sharing of ideas and content. And so I would say those are the areas, but it's been wonderful to be able to be part of something that is so just life-saving and about meeting people where they are.
Thank you so much for sharing those reflections, and for everyone joining today. I'm going to turn it over to Kristen to close us out.
Yes, thank you so much. And thanks AHP for being our headliner sponsor for today's workforce presentation. Very important. Next week, we are going to talk about the true cost of behavioral health with Dr. Margie Balfour and Matt Miller. And we're really excited. We're going to celebrate Margie as well as we officially induct her into the Crisis Jam 4-Timers Club. Sorry, we couldn't get Ryan Gosling to come, but it'll be fun still. 2 weeks out, Kelly Davis will talk to us about youth voices navigating behavioral health crisis. In 3 weeks, we will have debate number 11 with Megan Gleason and Dr. Ken Minkoff. And thank you so much for watching. Be sure to tune in, log on, join the movement, and we will see you next week.